Dear colleagues, I'm glad to be with you today to discuss a topic very dear to all of us. I think many of you are aware of this topic. I just thought to discuss what we are currently looking at as key findings or aspects or concepts or themes. I have only 15 minutes or so to present my topic, so it's going to be very quick. As an intro, I'm from Cleveland Clinic, Abu Dhabi. As you know, I'm a cardiologist and also very keen on quality and improvement. This is what we're trying to prevent. I think all of us know that when the endothelium is affected through dyslipidemia and other risk factors, all bets are off. The discussion of how low we should go is really almost established now. It keeps on going lower. I remember writing this article with my colleagues in SKMC. And while pleiotropic effects and anti-inflammatory effects of statins are important, there is no question that LDL is the problem. Not only LDL, but definitely LDL is a key factor. And there are genetics, epidemiological, interventional, and pathological studies to support it. So each slide here has a message. You can look at the data, but just as a summary, this is like a year in review or a 10-year in review. LDL is a causal factor of atherosclerosis. I think this is unquestionable. Meta-analysis of various methods to lower LDL cholesterol from the old fibrates and niacin and moving on to statins and ezetimibe all the way to PCSK9 inhibitor, the concept is clear. You lower the LDL, the cardiovascular risk goes down. Whether you have coronary artery disease and homozygote familial hyperlipidemia, heterozygote, the concept does not change. With absolute reduction in LDL, it's very clear that the risk goes down, and it's very clear and consistent. And that is something we need to keep in mind. The atherosclerotic disease progress and process changes with time, and obviously it depends on the phase of the intervention. And that has been shown from several studies from Cleveland Clinic and many other institutions. Regression of plaque is possible with adequate lipid-lowering therapy, as you can see in this study and many other studies. And actually, several patients would specifically ask you and I, is that true, and does it depend on the agent? And at least with statins, we know that that's quite true. Side effects are not related typically to LDL lowering, and this just came up a few days ago with a couple of my patients in Imperial College of London and in Cleveland Clinic, Abu Dhabi. The use of combination therapy for additive LDL lowering does affect and reduce cardiovascular risk. This was shown very nicely from the IMPROVE trial, was shown in Fourier trial, and also very importantly in the Odyssey trial, using alirocumab and the other agents. And this is an interesting slide that I want you to keep in mind. Even below LDL target, lowering even more than what we expect seems to be consistently lowering the risk. So I have here high is bad, average is not good, lower is better, even lower is even better, and lowest is best. And this is really based on data. Below LDL target, again, lowers the risk, and statin therapy is very safe. And again, this is like a quick review. When statin therapy is discontinued, and this we keep on mentioning to the patients and our colleagues in healthcare, the risk of cardiovascular risk and mortality markedly increases, as you can see in this study. After an event, initiating the right treatment at the hospital and talking about tobacco cessation and lifestyle changes. I've had numerous examples, and I'm doing the inpatient service next week, and I'm sure you all do. A reminder that that point of time is key to initiate therapy and also to change behavior as much as we can. And this is showing that LDL is really involved in all phases of cardiovascular risk reduction. A case just, very quickly, 35-year-old, family history very strong, blood pressure okay, LDL quite high. So, familial case here, LDL is 7.8. Framingham risk score 6 to 9% plus or minus, and I have no time to show you how I calculated this, unfortunately. So, Framingham risk score, LDL 7.8, what would you do? Would you treat? I'm sure you would treat. In this case, rosuvastatin was started 20, LDL went down to 4.1, then 40, 3.7, recommendations for lifestyle changes that I think all of you know, and we should continue to reinforce. 5 years later or so, the patient comes in, chest pain, unstable angina, severe mid-LAD stenosis with a drug-eluting stent. The LDL at that time, remember before it was 3.7, here 3.5, on rosuvastatin 40 daily. What would you do? In this case, ezetimibe was added, and the LDL went down to 2.6. As you know, the goals now are to significantly lower the LDL more. PCSK9 inhibitor was added, ellaham, and 75 milligram, which is the lower doses of this PCSK9 inhibitor, LDL was 1.3. Dyslipidemia in UAE, just very briefly, we do have some data, but not really much. Unfortunately, this is a humble review using an acceptable and a strong, I think, review method called evidence mapping of the literature with our dear colleague, Dr. Wael Mahamid, who never needs any introduction, a friend and a colleague, Lina Yassin from Imperial College, and our colleague Canwell from Dubai. You can review this article in the Saudi Journal. Very briefly, not to take too much time on this, no surprises. We looked at prevalence, which is high, awareness is low, screening is not where it should be, diagnosis concerning, treatment not where it should be, adherence and control is very low, at least from the published studies, and you can see the number of evidence to the left. I invite you to look at our recommendations and our summary of policymaker and governmental recommendations. Combination therapy, I think all of us know about it, but not all of us practice it as much as we can. All the literature supports it now, especially a fixed combination. And I think the reason is quite obvious. Number one, it works, it's in the guideline, and there are studies to support it. But even mechanistically, as you know, statin, most likely through HMG-CoA reductase inhibition, among other mechanisms, and obviously ezetimibe, would both work very well together, and I think all of us are aware of this. These are some very few publications the next 2 minutes or so looking at ezetimibe and the rosuvastatin, and not surprisingly, it works well. And this is another study looking at it from Korea, out of all places, which is very interesting. And they have quite a bit of data on lipid-lowering studies, as you know, and we know about the regression trials and many others. This is rosuvastatin, ezetimibe, and rosuvastatin, clearly a remarkable effect, more than doubling the dose of rosuvastatin or any statin for that matter. And I think all of us know about this, and probably this is quite established. The percentage reduction is remarkably more, and achieving goals based on the European Society guidelines and the American guidelines is consistently there. So basically, the fixed dose is here to stay, and I think it is quite underused, whether you use the first one with rosuvastatin and ezetimibe, or the one with atorvastatin and ezetimibe. But I think combination therapy is not even questionable. PCSK9 inhibition, very briefly, remember, when we are actually inhibiting PCSK9, we are giving the chance for the LDL receptor to be there and to take the LDL particle and lower our LDL levels and the patient one. And remarkably significant effect. I just saw a patient in Imperial College of London this past Wednesday, just a couple of days ago, and she has familial hyperlipidemia. Her LDL on maximum dose of statin and ezetimibe was 6, and using the PCSK9 inhibitors, her LDL was 1 and consistently 1, and this was on 2 occasions. Very, very potent drugs. This is the Odyssey trial. I think all of us know about it with ellaham, and I think the design is very obvious and the objective. Just as a reminder that we do have significant data with the PCSK9 inhibition. Very large number of patients. They included very interesting groups that are high risk, and I think the data speaks for itself with a follow-up of 2.8 years. And the outcomes were remarkable when it came to the outcome with a very significant statistical value. So really, in summary, with the very limited time that was given to me, it's quite challenging. And to keep you interested and to feel like at least we reviewed the literature, and that was really the goal of this fantastic conference. So thank the organizer and whoever invited me to speak to you. So the main principle for LDL lowering therapy is we have all the data, genetic, statistical, epidemiology, and trials that LDL lowering would help, but that LDL is definitely a cause of vascular disease. Till now, we have patients and very occasionally physicians revisiting this. So I think this is very strongly established. This is an algorithm. I'm sure you've seen it, but I don't know how many of us really review it carefully. So I'll go over it as I'm almost done with my presentation. You look at the total cardiovascular risk and you assess it, whether you score, which is typically what we use, or Framingham. Then you move to look at the baseline LDL levels, and we make sure, hopefully, that we have an accredited lab that is respectful and the numbers are reliable. Again, you can use millimole or you can use milligram per deciliter. The indication for drug therapy, all will need lifestyle changes. If we have a definite treatment goal, and I'll show you the slide at the end, we will use a high potency statin at the highest recommended tolerable goal and dose. The LDL goal is achieved, then, yes or no. If yes, then we follow the patient carefully. If not, we add ezetimibe, and ideally a fixed dose, whereby it's a one pill that has both, for compliance reasons and many other reasons. If the LDL goal is achieved, then you follow up the patient. If not, then you add PCSK9 inhibitors. And obviously, for insurance reasons, these need to be documented anyway. So again, you know about the high risk, the moderate, and the low risk. Just as a reminder, this gets to be missed sometime. Moderate CKD is high risk, and patient with diabetes without target organ damage and with diabetes with duration of 10 years, these are very important risk groups. This is the model of how you work with the lifestyle changes and the medical intervention. And this is a slide. If I had to choose a slide, if I was told, in 2022 or even the year before, choose one of the slide out of 10 to start a discussion on cardiovascular risk management or cardiovascular disease management, this would be the slide. It's very clear. It makes sense. It does talk about SCORE as a risk assessment tool. And obviously, many of our patients will need to be not only at 1.8 like the high risk, but very importantly at 1.4 millimole per liter and 55 milligram per deciliter. Incidentally, many patients complain that they are not very comfortable with the millimole per liter, and they find that milligram per deciliter is something closer to their mind. So any lab that can have both, I think it's a wise decision. And again, there is the extreme risk. So not only there is a high risk, but there is also extreme risk. And this was outlined in one of the publications from the American Association of Clinical Endocrinologists. And, it's interesting, they talk about progressive vascular disease, including unstable angina and established disease. Again, this slide, some of us maybe saw it to end, and some of us maybe did not see it. The goal of, I think, this conference and many other conferences is to transform healthcare from a reactive sick care to a care where we are really talking about prevention and healthcare, and where people live longer and we feel that we add value to the care of the patient. So I'm sure you know about the Chinese statement here, and this is a pretty wise one. The superior doctor is the one that prevents disease. And I'm sure we all want to be superior if we are not already. Several things came up to lower LDL, and there will be more medications, but we go back to the basics. Lifestyle changes should and will always be there and will be needed. And compliance, we in healthcare focus maybe on medication mechanism. We need to be more agile and more active and more flexible in talking to the patient. I'm sure you do this all the time. And also making sure that the compliance is not an issue. At the end, this is a humble experience that I had mid of last year and this year moving forward. This is with Wiley. It's a website that you may find to be interesting. And this is with, really interesting faculty that I'm honored even to talk to or communicate with, Chris Cannon, Dr. Deepak Bhatt, etc. And, there are quizzes, videos, meetings, interviews, articles, and many other things. You may like to log into it, and it may add some value. I thank you for your attention. Have a great day, and I'm sure you're having an amazing conference. Thanks again.